Hello, everyone. Today I have a lovely guest with me today, and I'm so honored that she's with me today. And it's Dr. Lisa Littman. She is known for her studies on rapid onset gender dysphoria, and we're going to talk a little bit about that today. We're also going to talk about detransitioning and the trans community and how they're behaving. Lisa, welcome.
Thanks. Thanks for having me.
And can you start introducing yourself a little bit?
Sure. Well, my name is Lisa Littman. I trained first as a physician and practiced OBGYN for several years. And then I switched to research in public health. And that's what led me to my research where I am today.
Awesome. And what made you interested and wanted to start researching about gender dysphoria and rapid onset gender dysphoria?
Yeah, it wasn't my primary area of focus, but I noticed about 2014 or so that teenagers in my community had started to identify as transgender, one after the next, in numbers that were much greater than expected. So the first one came out, actually, the first two came out together, and I thought, wow, that's great. I'm so happy that they're comfortable making these announcements. But then a third, a fourth, a fifth, a sixth. And it turned out that they were all from the same friendship group. So this piqued my interest. And then I started reviewing the research, and that led me to my current research.
Awesome. Yeah, that makes sense that you become curious when you see stuff like that happen. And what was the research process like? Because a lot of research you see on the topic, it's very woke. So how did you approach this issue compared to others?
Well, at the time I started this, the research, this was several years ago, so it wasn't as maybe ideological as it is now, perhaps. Maybe it was the beginning. So I wanted to approach this from a curious and neutral way. So, as an individual, I'm liberal, I'm pro LGBT. My inclination is certainly very supportive, and that is a foundation. And I wanted to see what was going on because this might shed light on the process and may be helpful in terms of figuring out how best to help people. But at this point, I was noticing a phenomenon and wanted to find out more about it. So, getting back to, you asked me about the process. So, after I noticed individuals in my community, I went and did a deep dive in the research literature, and I didn't see anything that was suggestive of friend group onsets or individuals of this nature. I read about early onset gender dysphoria, late onset gender dysphoria, which up until 2012 only consisted of male individuals in the literature. So that was intriguing. I also did a deep dive into the social media world because I wanted to see what kids were communicating to each other on this topic. And I found a very surprising environment where individuals would go online, they would say, I'm lonely, I'm uncomfortable, does that mean I'm trans? And then immediately individuals would jump in and say, oh, absolutely, that means you're trans, you need to transition as soon as possible. And there was these dynamics that reminded me of some of the dynamics around the social contagion of eating disorders. So individuals that were highly praising anybody who was transgender identified, who was transitioning, but a active animosity towards individuals who were not trans identified. So the in-group, out-group dynamic also intrigued me. And so that was the process, um, the first process, and then seeing whether anybody else was reporting this. Is this just my little tiny suburban town in Rhode Island, or is this happening elsewhere? So I had to look online to see if anybody else was reporting this phenomenon where kids weren't gender dysphoric or in distress about their gender as children, or even going through puberty, but then within friend groups started to identify and come out as gender dysphoric and as transgender.
Awesome. And I'm not sure, did you come up with the term rapid onset gender dysphoria?
I did.
Oh,
So when I started, there was no word for what I was describing. So I was using the long form of, well, the thing where an individual doesn't show signs of gender dysphoria before puberty, but then becomes gender dysphoric during or after puberty. And that's a mouthful. That's quite long to keep
yeah.
writing. So I needed something shorter. And so my goal was to pick something that was descriptive and that was neutral. I really was sensitive to make sure that this couldn't be seen in a negative light, only as a just very neutral descriptive term.
Yeah, I think it's a great term. And I like to use ROGD for short because that's even shorter. Um, so you worked at Brown University as a researcher?
Well, it's a little bit more complicated than that. When
Okay.
I started my research in this area, I was affiliated as an adjunct assistant professor at Mount Sinai. And then during the process, I became an assistant professor of the practice at Brown School of Public Health. So
Okay.
the works sort of shifted from one university to the next university. And so when it was published, I was affiliated with the Brown School of Public Health.
Oh, okay. And what was your experience publishing your controversial research?
Well, I was not expecting it to be this controversial, actually. Um, so that was a little bit surprising to me. I heard some inklings online before publication, and I thought maybe there'd be, some people who were not pleased, but that's nothing new in public health. I mean, it's kind of commonplace that that research does not please all individuals. So so at Brown, it was interesting. The first emails that I received were congratulations for shedding light on a very complicated topic. But shortly after, there was a social media uprising. There were people who were very upset by the research and were making claims of that it was transphobic, and they were tagging the university and the journal. So
Uh,
at that time, I was naive to think that social media was separate from academic institutions and journals, but it was a seamless uh, transition in terms of how that communicated. And I heard that that Brown heard from other people as well. So yes, then it became fraught,
mm,
definitely.
yeah. And was it something about because of the backlash Brown got that they replaced your studies with like an apology or something like that? They
That's well, it's not exactly like that. So the study was published through the journal PLOS One.
mm,
What Brown had was an announcement of the study. So there was an
okay.
announcement of the study on the website, on the Brown website. So that's what they pulled, their the announcement about the study, and then also issued a statement to the community.
What
Yeah.
community? I mean, wow, that's crazy. Because they someone got so offended, so they just took it down. I think that's crazy.
Yeah, I mean, to be fair, they do have, I believe, the final say of what they put on their website and don't put on the website because it's their website. But I came to realize that this process was highly unusual, the way that this came to be. The former dean of Harvard Medical School, Jeffrey Flyer, wrote an essay talking about how surprising it was how Brown responded to the conflicts. And also with the complaints, the journal decided to do a second post-publication review. So these things happened rather quickly and around the same time. And I believe Brown's statement says that they pulled the article because of the decision for the post-publication review or something like that. So
how did you feel about that when it was happening? It's a while ago, isn't it?
It is. It was in 2018. It was stressful. It really was stressful and surprising, especially after all of the work that went into the process of getting it published. So up until that point, it had been completely the usual process of doing the research, writing the manuscript, submitting it, undergoing peer review, then responding to the reviewer comments, going back and forth. So it was really, up until that point, it was straightforward. And then I thought we were done once it was published. Yeah. But then there was a post-publication review, and the information I got from the journal is that they wanted it to be better framed, that this was a study where the information was collected from parents, and that rapid onset gender dysphoria was not a formal diagnosis.
Right.
And interestingly, the amount of emphasis in the first paper about this being a parent report study was at least, if not more, emphasis than usual. For example, there's a study that is very highly praised and cited by individuals who endorse rapid transition. It's a study about social transition and mental health. And that's a parent report study. However, it didn't say parent report in the title. It described it in the methods, which is commonplace. And maybe there was one or two sentences describing the limitations. So my original paper already had more emphasis than that one. But, I think because the controversial nature, they really wanted a lot more emphasis than, I think I've never seen a parent report study that had more emphasis that it is a parent report study, and discussion, which I had sentences and sentences describing the limitations of a parent report study. The other thing was about needing to emphasize that it wasn't a formal diagnosis, which is surprising because how could a first report of something already be a formal diagnosis? So anyway, I added that. And then I also heard that they wanted to be especially clear because the topic was of interest to people who are not scientists. So there needed to be an extra sensitivity so that, the statements weren't misunderstood by non-scientists.
Yeah.
So
it's a lot of work to explain yourself.
Yeah. And unfortunately, I had a consulting job around that time, and some clinicians who were very pro-transition wrote to the leadership of where I was working, demanding that I be fired, even though my job had nothing to do with gender dysphoria. I was doing maternal child health, prematurity, immunization. I was a consultant. And they demanded that I be fired immediately. And ultimately, God. I know. It's just, it's very unprofessional to do something like that. And so what ultimately happened was I was called in to explain my research, And they decided not to fire me immediately, but rather to wait until my contract was up and then not renew the contract. And it's very clear to me that the non-renewal was directly related to this letter,
Mm.
because my colleagues had already submitted the paperwork to renew my contract. So
Oh, okay.
yeah, so it was, things were in process, and then the decision was made. So, that's a pretty powerful, let's say, disincentive for other people to study controversial topics.
Yeah, yeah, it's a risk, but it's so important that people like you are out there and are doing this research. And speaking of the study, so the QIA plus community, I call them, like the woke side of the LGBT community, they keep saying that rapid onset gender dysphoria is a myth, because you included parents and not the trans identified teens in the study. So, what's your initial thoughts on that?
Well, that doesn't actually make it a myth in terms of the way that you collect data. Um, and I have two things. One is, as you know, the community is not a universal community where everyone has the same beliefs. And there are many lesbian, gay, bisexual, and trans individuals who are supportive of this work. So it's not an all or none kind of thing. But as you mentioned, there is a very vocal community that's very opposed to this work.
Mm.
Regarding its describing it as a myth, the other thing that gets lost in the discussion is that my second paper about detransitioners supported several of the findings by firsthand accounts. So yes, the first study was parent reports, and it's not uncommon to collect information about children or adolescents from their parents,
Yeah.
individuals who know them well. But then the next step is going to first person accounts, which I did with the detransitioners. And so the detransitioners described that their gender dysphoria, some of them, began during or after puberty, and described that there were social influences, that they felt pressure to transition, that the reasons when they look back for their gender dysphoria was they believed that it was caused by a mental health condition or trauma, or that the whole thing emerged from difficulty accepting themselves as lesbian, gay, or bisexual. And there were a lot of different reasons, which I think opens the door for discussion and the importance of not to oversimplify and think that there's only one cause for gender dysphoria, one treatment, but there are a lot of things that can cause someone to feel gender dysphoric. There are a lot of things that, that can contribute to that. And depending on what that is, the treatments are going to be different. Like, you don't want to treat trauma from rape with mastectomy
Mm.
as your first course of action. So that opened up. But I think the issue about the social contagion that people are very up in arms about, there are several things from the detransitioner study that supported the social influence. So in terms of people feeling pressure to transition, individuals listed the forums, online communities, and their friends as sources. And there was one question where I asked individuals how they feel now about identifying as transgender in the past. And more than a third responded with the answer, or endorsed the answer, that someone told them that the feelings they were having meant that they were transgender, and they believed them. And so I think this speaks to a social source, a social cause that contributes to how people interpret their own feelings and come to the conclusion of being transgender. So there are, for some people, a social contributor. We haven't done the studies yet to say, yes, this is social contagion or not social contagion. That takes a different kind of study in terms of looking for clusters.
Mm.
But that hasn't prevented individuals from claiming that they have disproved it without doing those studies.
Yeah, but it makes
Yeah.
sense that these detransitioners who are now young adults, that they can now see what happened during that time when they were teenagers, and very heavily influenced by, activism and social media. You can't ask a child when they're in that state, is this a social contagion? Like, you have to ask the parents because they know their children best, actually. And especially if, because many of these individuals, they have other mental health issues. So with that said, you don't, if you're dealing with mental health issues, you don't always know yourself the best. That's why you need like a doctor, a therapist, and like your family also knows you pretty well. So I think it's ridiculous to say that your study is a myth. Like, I don't get it. Why do you think they call it that? Like, why do you think they're so angry with you, like some of the people from the trans community?
Yeah, I think that this is the reason that this has really riled people up is that there are some people that are very committed to fast tracking transition as the only solution. And so this study, as well as the detransitioner study, brings up reasons why perhaps that's not the best approach for every person. And what I think is wrong with this discussion currently is we should prioritize the health and well-being of individuals who experience gender dysphoria. And that means individuals who have gender dysphoria that persists or resolves, people who transition, people who don't transition, and people who are helped by transition and people who are harmed by transition. And that should be the priority. And if you're prioritizing that, you're going to look at each of these approaches and think about what are the pros and cons for each approach. And you will want to know when it is likely to help and likely to harm. And what I think has happened is we've flipped the script, some people, and instead of prioritizing health and well-being, they are prioritizing fast tracking transition as the end all be all way to help people and to show your support for individuals who are trans identified. And so if you look through a lens where the outcome has to be fast tracking transition, then anything that raises questions is going to be pushed back against. So those are my thoughts for why this has been so contentious.
Yeah, I mean, I also feel bad for these individuals because they're not getting the proper help. I mean, if they're suffering from other mental health issues, they're not getting solved by transitioning. So I think it's very sad, and wrong to not, as a doctor or therapist, like, if you clearly can see some symptoms of other mental health issues, like, why can't you, why can't the individuals get the help that they need? Like, why do we just blindly affirm their trans identity, them being trans, and give them hormones and surgeries? So do you agree that we also need to look at the other mental health issues that remind, or these there's some mental health issues that also reminds, what's it called, like, uh, that's similar to gender dysphoria. That's the word I was looking for. So do you think we also need to focus on that?
100%. Absolutely. I think there are two really important things to focus on in terms of mental health. One is we don't want to leave people suffering with their mental health issues untreated. So by fast tracking transition and closing your eyes to everything else, you're really depriving vulnerable individuals from the kind of support and mental health services that they need.
Mm.
The second thing is you want to be aware of the mental health conditions or other or other conditions that might look like gender dysphoria and lead somebody to make a misdiagnosis. So I think there are two, and probably many more, aspects about mental health and the importance of evaluating patients and making sure that they are treated with the kind of mental health services that they need. There's a phrase that I think it came up in the CAS review, but called overshadowing, in terms of when you, well, this is something that is individuals should not do. So when you get to a diagnosis such as gender dysphoria, it's basically closing your eyes to every other kind of diagnosis a person may have and just focusing on that. And I think that's something that happens as well. And that's what I've heard in my data from parents and as well as from detransitioners, that once you say the words gender dysphoria and once you say the words transgender, that all of a sudden everybody ignores your mental health symptoms, your mental health conditions, and there's sort of this blind oversimplification that, oh, just transition and it's going to fix everything. But so yeah, I think that's a real, it's a real concern
Mm.
that people are getting deprived of mental health services.
Yeah, I see on Danish TikTok that all these we have a lot of weird TikTokers here, who are clearly going through some stuff, and they're not, you know, they have some mental health issues, but then suddenly they just identify as trans, and now they're not weird anymore. You know what I mean? Like they become popular, and so before they people would make fun of them in the comment section, and now it's like slay queen, trans queen, whatever. And I think that's a real thing. Like the affirmation and the validation, it means a lot to some people, but if they go through a medical transition, they're not going to benefit from it. They're going to regret it in the future. So it's really concerning. Yeah.
Right. I mean, some people are helped, but some people aren't. And it's a shame that the affirmation and support is coming just from that. Like, wouldn't it be nice if people were just getting this kind of support for, for being a good person, for making healthy choices, for just being a human being, getting this kind of support. But I think if maybe you're missing that kind of support, that this can be especially enticing.
Mm, exactly. I've also seen a little bit from the QIA plus community how they're talking about the parents in your study. They're transphobic, and I'm pretty sure they're not. But can you explain your experience with these parents?
Sure. I think it's really important to talk about the word transphobic because it is an important word and it's an important concept. And there is transphobia in terms of individuals who have a hatred of trans individuals and might want to deny them rights. And so that's a real powerful and negative thing. I think it's a problem when you call things that aren't transphobia. And I think that's what's happening, in that what we've come to culturally is that anything that's not fast tracking transition gets erroneously called transphobia or being transphobic. And I think that's what is getting directed at the parents in the study of my first study. I hear from parents all the time, from the study, but also continuing parents do reach out to me. And it's very common for people to spell out that I'm not transphobic, I support LGBT rights. I just think that this doesn't make sense for my child, and I'm afraid that my child is going to do something that they will regret. So in a non-ideological world, we should view parents in terms of, yes, they're trying to do the right thing for their kids, But there are parents who believe transition is going to hurt their children, and there are parents who believe that transition is going to help their children. And so that's how I think, is a better way to talk about the parents who perhaps are in my study versus the parents who are in the social transition study. That if you're looking for parents who believe transition is going to help versus parents who believe that transition is going to harm their child. So that's really my take on the parents, because what I'm hearing from parents in the data is that these parents love their children and they want to help and protect their child. And often they will also say, if this is going to make them happy, then you know, I will support it. But really what's driving them is this fear that that their children are going to be harmed.
Hmm.
And I don't think that's transphobic. I think that's looking for the right treatment for your child, and that's protecting your child's health.
Yeah, it's a valid concern, definitely. And the word transphobic doesn't really mean anything anymore, unfortunately. I'm being called transphobic. I'm trans myself. I guess you've been called that plenty of times.
Yes, yes. And other trans individuals are being called transphobic, which,
Mm.
kind of makes you stop and think, like, hmm, is this an appropriate, insult? Is this how we should be treating people? Are the people throwing around the insults correct?
Mm.
Or are they misusing the term? Because when individuals who are trans are getting called transphobic, it makes you stop and think, like, hmm.
Yeah. So let's talk a little bit about these, especially young teen girls who are rapidly identifying as trans. Who are these girls?
So, what I've heard is that individuals, and this is also in my study, are teenagers who may be struggling with a variety of things, such as mental health conditions or social isolation, and may have a lot of other things going on, who get involved in their, either hearing it through their friend group or through online sources, that many of these symptoms mean that they're transgender and that transitioning is going to make them feel better. And I think it's important to, in general, have a lot of compassion for people who are in pain. This is not something that people are doing to be, you know, for lighthearted reasons. Individuals who are experiencing pain look for ways to feel better and often will gravitate towards the first solution or even a coping mechanism that they might see. And so 20, 30 years ago, individuals may have seen extensive, strict dieting as the way to make their lives better, because they, in that situation, are told that they're unhappy because they're too fat or that they're overweight. And so one coping mechanism that was a maladaptive coping mechanism that is part of eating disorders is this belief that dieting and losing weight is going to be the solution, and this is going to make your life better. And so I think there are some parallels here, and important to recognize that individuals in pain will try to find things to help them feel better.
Yeah. And I also think when we're broadening the term of what it means to be trans, you more people will relate to that term, even though it's far away from reality. Like being a transsexual is only very, very few people actually experience gender dysphoria and a medical transition. But now, when the trans community says that you don't need dysphoria to be trans, and with all these new made up genders, so many people are gonna be confused about who they are, and as you said, if they're experiencing pain to begin with, they can easily yeah, be misled.
Right. And you're exactly right about the way that the definitions are becoming broader and broader. So it's interesting, this idea that you don't need gender dysphoria to be trans, but yet you should have access to transition. So it's interesting because, from a medical perspective, when you provide an intervention, if there are risks, and everything has risks, benefits, alternatives, there needs to be something to justify taking those risks. And if you don't have a diagnosis of gender dysphoria, it seems surprising to me that the people would just, providers, clinicians, surgeons, endocrinologists will just not take that into account.
Mm.
So it doesn't make sense to me that if somebody doesn't have a diagnosis, they're not experiencing gender dysphoria, why that would, it's outside of medicine, the way that medicine usually operates.
Yeah. Yeah, and I think another thing is it's important to destigmatize dealing with a medical condition,
Yes.
diagnosis, whatever you want to call it. There's nothing wrong with having a diagnosis. Um, so that's what I get backlash almost the most for saying is it's a diagnosis um, to be trans or to have gender dysphoria, but there's nothing wrong with it. And I, me personally, I got a treatment that made me feel better, but it was a medical treatment, and you can't receive a medical treatment if you don't have a diagnosis. So, I mean, make it make sense, as you said. Um, so, so these girls, so back in the day, gender dysphoria was in biological men, right? And now we see a switch.
Yeah, it's very interesting. So, for decades and decades, the typical patient that was seeking transition was a middle-aged male.
Oh.
And the people who were attending clinics also for decades were children that were predominantly male. And sometime around the mid 2000s, gender clinics started to see an uptick in adolescence, and this reversal of the sex ratio. So where it was predominantly male and very small numbers, it now became predominantly female. And so this is this is a huge difference. Not only that, the increase goes up really astronomically quickly. And so it's really negligent not to ask questions about why this might happen. And when you're seeing these increases, and I think the UK has documented that a 4,000% increase in teenage girls seeking transition over a period of less than 10 years.
In Denmark too.
Oh yeah. And so when you see those kind of astronomical changes, you don't just, make supposition, just throw out anything and then accept that. So individuals will say, "Oh, it's just because there's less stigma or more information." And that might be true of some of it, but it doesn't explain the whole constellation of what's going on, and it hasn't been studied. But yet people kind of dig in their heels and say, "Oh, that's the only reason." When you see these huge changes, it's probably many things that are contributing to it. But it's really important to get to that understanding, because what if this kind of gender dysphoria is very different than those other gender dysphorias and won't respond the same way to the treatments? So I don't know. I like the example of breast cancer. Like, let's say you're a surgeon or an oncologist, and for decades and decades and decades, your patients with breast cancer are overwhelmingly middle-aged female. And let's say in a period of 10 years, you start having patients that are teenage males with breast cancer. And that, within a short period of time, becomes the major breast cancer patient. And so if you're not asking, is this something completely different? What if this is going to, respond differently to the treatments that we've been given to middle-aged females in that kind of breast cancer? It's just irresponsible. And so I think it's a good parallel going from middle-aged women to teenage boys, describing, as a sort of an example for breast cancer, because we've gone from middle-aged males to teenage girls, and that's a big change. So if you don't want to hurt people with your treatments, you need to be cautious and be thinking about, why has this happened? Is something new happening? And how are we going to figure out how best to help these people who may be very different than the people we treated in the past?
Mm. And also with teen girls, as you said before, that back in the day, they with social contagion, you saw girls with symptoms of eating disorders, kind of experiencing that together in a friend group and stuff like that. So it's not necessarily a new thing. It's just a different, and I'm just going to say it's a different way of self-harming, because it is self-harm if you don't have gender dysphoria, but you go through a medical transition. It is a form of self-harm. Um, so it's not that unseen, and I think we need to be really careful about who's receiving a medical transition.
Right, absolutely. And as you mentioned, social contagion is not new. I mean, we've seen this for eating disorders, for depression, for anxiety, for rule breaking behaviors. There, I believe it's Dr. Erica Anderson said something to the effect of, why would this be the exception? Teenagers are influenced by each other. That's not, it's not a put down. It's just, this is how we are as human beings. We are connected as human beings. And why would this be the only exception? And recently, there's been this really huge expansion of neurological tics, Tourette's-like syndrome,
Yeah.
that individuals, that clinicians are are believing may be traced back to some influencers, because of the type of, the patients that are being seen are atypical from what used to be seen. The onset is sudden,
Mm.
and the tic behaviors, such as saying the exact same phrases,
Mm.
really points to something that's not sort of an organic process that may be related. So yes, and we're connected way more than we ever were. So
Mm.
when I was a teenager, your friend group was generally the people you see every day. And now we're connected by social media to like hundreds and thousands of other people, and people form friendships this way. So
Mm.
it's surprising to think that this couldn't have some sort of contribution.
Yeah. And you also see it a lot with DID, um,
Mm,
and people faking it. And I feel bad for saying that, because I think if you're faking having DID or Tourette's or anything like that, or being trans for that matter, I think you're dealing with some stuff, and I feel really bad. I remember I started doing talking about these topics a couple of years ago, and before I was very, you know, um, it was more about making fun of the other side, being angry at the other side, like the fake transsexuals and the activists. But now I've changed kind of my yeah, my tactic, or like the way I'm looking at it. It's quite different now, because these people are also in pain, and I know of all people what it's like to not feel comfortable with yourself. So I hope that they get the proper help. And I know it's not transitioning, whatever it is, I support them, because there's no reason to fight like cats and dogs. And I don't think it's even that political. It's more psychological, right? So it helped a lot to change the way I looked at it.
yeah, and I think that's a really positive thing, to shift from how you see people and just extending this compassion and sort of a curiosity of, what might be driving them to do these things, and what are they experiencing?
Yeah. So there's something I've always been curious about, because maybe I have just misunderstood the whole thing, but with gender dysphoria, So you don't really use the term here in Denmark at all. So that's why the things I know, like technically from gender dysphoria, other than me experiencing it, it comes from the U.S. So you said three types of gender dysphoria. So I thought it was only one type of gender dysphoria, and then either you have it or you don't have it. So, but you mentioned three different types, right?
Well, yeah, I categorize them a little bit differently. So there is the early onset gender dysphoria, and that occurs in children, and can occur in boys and girls. And that's what I think people think of when they think of a typical history of a person who is transgender,
Mm.
that they picture somebody who from a very early age starts to express that they believe they are the opposite sex or that they identify with the opposite sex. And so that's early onset. And the majority of individuals with early onset will actually desist in their gender dysphoria. So their gender dysphoria, for most of them, will resolve during adolescence, by the time of early adulthood. So there's a lot of controversy there about the studies because some people don't like the desistance studies, but it is the best data we have. Quick side note is that one argument is that people who don't want to accept desistance will say, oh, those kids were just gender nonconforming. They weren't gender dysphoric because not everybody who was in the study met the criteria. And so Dr. Ken Zucker went back and reanalyzed and looked just at those that met full criteria and found that the rate was about 67% desisted. So I think that's an important rebuttal to, oh, you can't learn anything from this. And the other thing is there's this argument that, oh, they were just gender nonconforming. But actually, if you look at the DSM, the manual,
Mm.
in every DSM edition that has gender dysphoria or gender identity disorder in it, it explicitly says this diagnosis should not be applied to individuals who are just gender nonconforming. So, so we can say that this is the pathway for most individuals with early onset gender dysphoria. Then this other type is the late onset male type of gender dysphoria, possibly more controversial, or at least as controversial as the idea of rapid onset gender dysphoria. But this is typically what we saw previously was middle-aged males who become gender dysphoric and trans-identified. And this is usually related to a sort of a sexual connection, so that they are aroused by the image of themselves as a woman. And so people kind of push back against this. But if there's an activity that leads a person to masturbate, I think it's pretty clear that there is some sexual connection. So it may not be all males who have late onset gender dysphoria, but this is another type of gender dysphoria that has been studied, and individuals who experience this have reached out to researchers and clinicians and said, thank you for researching. So that's autogynephilia, AGP. So that's a second type. And then what we're seeing now is maybe a third type, sort of adolescents who are becoming gender dysphoric without a history. And it's hard to know, with females, it's not likely to be an AGP kind of picture. With males, it's a little harder to tell, but it seems that the histories people have do seem similar. But again, it's going to be it's going to be difficult to suss this out and figure out exactly. But clinicians around the world, even from the Dutch clinic, have said this is something new, this cohort of teenagers that are becoming gender dysphoric. And so that's sort of a third type that is highly contested.
Yeah, that's very interesting. I mean, the topic of gender dysphoria alone is so complicated. And many people, they think that the trans topic is very complicated, but this is even a deeper layer of some sort. But I find it so fascinating. I find people very fascinating. I've seen videos from people who regret the whole thing before testosterone, like before receiving it at the doctor. And then I've seen heard stories from biological females who've gone through it all, like the hysterectomy, the bottom surgery, the mastectomy, 8 years on testosterone, and it breaks my heart because you cannot reverse that. Um,
Oh,
but yeah, I think it's heartwarming that we have in some way that we have a detrans community, because I think it's good for them to be a community and learn from each other and feel loved, because they're not loved in the trans community so as much. Um, but yeah, I think yeah, you're right. They're not always ruining their lives. I mean, especially if they're young, they have a future, and if they live here in the West, there's a lot of ways to live a normal life. Like, do you know what I mean? To reverse the changes and stuff like that. So yeah, you're right.
yeah, a lot of people, I mean, people have very different experiences. And so just, understanding. So some people, as you know, and as you've mentioned, are happy with their transitions. Some people feel intense regret. Some people are kind of ambivalent in between. And so we have a very long life trajectory to kind of to get through. Um, but yeah, in terms of what there's research about detransitioners in which many have said that they have been ostracized and kicked out of LGBT communities when they detransition. And so that can be very difficult because this was their support network.
Mm.
But when they detransition, yeah, unfortunately there is a lot of animosity. And one of the things that led me to research detransitioners is that they're people, and they are valid, worthy people who deserve respect, and they weren't getting that. So that's important. And the other thing is their experiences are really important in terms of informing us on the other end of how we're doing evaluations and how the treatments go. In every field of medicine, there is really an intense desire to know what the outcomes are, and not just the favorable outcomes. You
Mm.
want to know all of the outcomes, because that's going to inform how you evaluate and how you treat. And so what's been unusual in this discussion is that there are clinicians that only want to hear the good outcomes.
Yeah.
And that's doing a disservice to every individual who's transgender or gender dysphoric, because they all deserve a full, complete, accurate description of what the outcomes may or may not be.
Yeah. And not only the outcome, but also the I know personally, my trans doctor, she focuses more on the good things about testosterone, like the good changes that makes me pass more and all this stuff. Um, but I was never informed about any side effects really until I experienced it and told her, right?
Mhm.
And I remember talking to her about some side effects that really made me depressed, because I didn't know it was going to happen. So I felt a little. Um, the thing she said, and she's a doctor, she said, all you have to do is be you, be Marcus. So that's very concerning to me, that she's a doctor, but clearly I can sense her ideology um, that's affecting her advice and stuff like that. It's very sad.
Yeah.
But to wrap it up, what do you think we should do um, when it comes to these teenagers who might experience rapid onset gender dysphoria? What should we do in the future?
Well, it's I don't want to give advice since I'm not a clinician in this area. However, the research and what we're learning about detransitioners, and about all of the different trajectories that bring people to gender dysphoria and the need to transition raises the issue of needing to be much more thorough when a teenager comes to the doctor for an evaluation. That rubber stamping, fast tracking transition seems to fly in the face of what we know in medicine. There are very few interventions that are given to people without any evaluation. So I think basically getting back to the roots of medicine and psychology, in which you actually get a full history and you learn about the patient from, from multiple sources, get the whole history, make a differential diagnosis, which is listing all of the different things that could be going on, and proceeding cautiously. And again, there's not going to be just one answer for every person. It's not like nobody should get transition or everybody should get transition. This is about, we should be focused on making sure that the right patient gets the right treatment. So what I would say is we should go back to ethical, medical, and psychological practices and not allow this complete disconnect in this area.
I totally agree with you, especially because we as a society support LGBT rights and people. So when you say going back, of course, it's not before that.
Oh, 100, yes, yes.
So we have to appreciate that everyone is tolerant and supportive of LGBT, but we need to take a step back and not, become too extreme. So yeah,
Oh, absolutely. Yes, and many of the individuals who are coming through, and a lot of the detransitioners, are lesbian, gay, or bisexual. And so we want to make sure that we're not derailing their development by jumping in with interventions. So absolutely. I mean, this comes from a place we need to support and be tolerant and all of those good things about lesbian, gay, bisexual, trans individuals.
Mm. Well, thank you so much for coming on my channel. I really appreciate it. And yeah, I hope to hear from you sometime soon.
Yeah. Thank you so much. It was a pleasure speaking with you.
Thank you.
Thanks.